Welcome to Lesson 1, where we will focus on attention deficit hyperactivity disorder, commonly referred to as ADD, but that is really referring to an older classification in a previous edition of the DSM. The DSM-5 classification is attention deficit hyperactivity disorder, though there are specifiers, and one of which can be inattentive type. I still have patients today who will correct me if I mention attention deficit hyperactivity disorder when it is a child with inattentive type. The parent will always say, oh, no, he doesn't have hyperactivity. It's just ADD. So anyway, just wanted to make that clarification. And the verse guiding this lesson is from Mark chapter 10, verse 15 and 16. I tell you the truth, anyone who doesn't receive the kingdom of God like a child will never enter it. Then he took the children in his arms and placed his hands on their heads and blessed them. Some cultures and generations consider children better seen and not heard. Well, that can be very hard to do with a child with attention deficit hyperactivity disorder, who can be very challenging. It's important for us to help all of those who encounter our patients with ADHD to likewise receive them with a positive focus. So in your textbook, it identifies attention deficit hyperactivity disorder as affecting 3 to 5% of children. In the US, the incidence is actually even higher, and many sources cite it anywhere from 9 to 11%. It does affect the neuropsychological functioning as well as having some neurobiological correlates that can be identified in scans. It is common in all cultures. It can be very serious because it can lead to academic failure, accidents, stigmatism, and punishment. And it is treatable. It is treatable with both medication and behavioral therapies. Some kids benefiting from one approach or the other, but many really requiring both. And kids with attention deficit hyperactivity disorder have a high incidence of other psychiatric comorbidities. The CDC identifies the prevalence of attention deficit hyperactivity disorder in the US as 9.4%, and this is based on the National 2016 Parent Survey. Our textbook refers to worldwide epidemiology and prevalence of ADHD as 6% or 3% for adolescents. It does occur more frequently in males than females, and the National Survey 2016 showed a incidence of 12.9% for boys and 5.6% for girls. And so we do see quite a large disparity there. Oftentimes, girls are overlooked and not diagnosed with ADHD because perhaps better verbal skills or more behavioral control and more compliance. Now, there are two terms for attention deficit hyperactivity. Certainly, that is the DSM diagnosis definition. But according to ICD, it is often referred to as hyperkinetic disorder. Impulsivity, inattention, and hyperactivity are common symptoms in preschool age children. And so the diagnosis of ADHD is not commonly made earlier than the age of 4. And the developmental presentation of ADHD symptoms looks very different dependent upon these stages. So preschool age child with ADHD has trouble playing with an activity for more than 3 minutes, and often have trouble listening and appear to have no sense of danger. School-age children with ADHD have trouble attending to one activity for 10 minutes or more, and are often very forgetful, distracted, restless, intrusive, and disruptive in the classroom. Adolescents with ADHD have trouble attending for 30 minutes or more, and also have great difficulty with executive functioning and trouble focusing or planning, and may also appear fidgety. Also, impulsivity and reckless behavior can occur. Adults with ADHD have trouble attending to details, are very restless, forgetful, can be impatient, interrupt, and often have frequent accidents. It's commonly thought that many children can outgrow ADHD as the central nervous system matures, and however, many actually are learning compensatory techniques. So some, however, are chronic courses throughout adulthood. Now, ADHD certainly does occur on a spectrum as well, where some children and individuals can be mildly impacted and some more severe. So, about 15% of the cases can be considered having a full persistence or that chronic course, whereas a higher incidence can have a partial or even a full remission. So, the more severe the symptoms, the longer the persistence commonly, and durability of symptoms is also associated with negative outcomes, such as a lower academic achievement. Individuals with more chronic cases can have marital problems, marriage dissatisfaction, divorce, and difficulty dealing with offspring. Adults with ADHD also can have a lower job performance, unemployment, and often are maintaining job positions much below their potential. They also have more frequent traffic accidents and the increased risk for developing other psychiatric disorders, such as substance use disorders, depression, or anxiety disorders. These considerations are for individuals mainly with inadequately treated or untreated ADHD, as well as those with very severe um, incidents or occurrences of ADHD. There is a strong genetic component, with up to 76% of children with ADHD having a first degree relative as well with ADHD. Now, perinatal factors can also be associated with ADHD, and these include prematurity, low birth weight, as well as intrauterine tobacco exposure. Neurobiological deficits can occur, and these are slight differences, not brain damage, but some differences in executive function and inhibitory control are identified with some differences or changes in the frontostriatal dysfunction, as well as catecholaminic dysregulation, and overall a delay in cortical maturation. Deprivation and family factors are also considered, as poor nutrition, poor nurturing, and early childhood care can have an increased incidence. So, children in lower socioeconomic situations, as well as institutionalized children, are at higher risk. There are a number of associated features or comorbidities with attention deficit hyperactivity disorder. And these include defiance, aggressive, or antisocial behaviors that may or may not meet criteria for an additional diagnosis of oppositional defiant disorder or conduct disorder. Kids with ADHD often have problems with social relationships because their impulsivity can cause them to be annoying or considered annoying by their peers. And so sometimes they're avoided or stigmatized. And however, social anxiety disorder is a common comorbidity as well. So they may or may not meet criteria for that, but it is important to consider as a differential diagnosis as well. Um, their IQ may be lower than the general population, but this is not always so. They may have another specific learning disorder in the area of math or reading, but is not also necessarily so. They may have soft neurological signs upon physical examination and just appear a little uncoordinated. And some will have a developmental delay. Another comorbidity may include disruptive mood dysregulation disorder, or they may just have poor emotional self regulation. And the common comorbidities include oppositional defiant disorder, anxiety disorders, conduct disorder, major depression, enuresis, bipolar disorder, and DMDD or substance use disorders can co occur as well. There are various assessment scales or behavioral rating scales that can be utilized for the diagnostic process, and they are assessing a number of symptoms in the area of inattention, hyperactivity, or impulsivity. And remember, diagnosis needs to be assessed based on two different settings. And so school is usually the second setting, and teachers are key informants. Rating scales often include the assessment for inattentive symptoms such as distractibility, forgetfulness, inability to finish what they're starting, as well as hyperactivity, always on the go, restless, fidgeting, talking too much, unable to play quietly, and impulsivity, unable to delay gratification, trouble taking turns, acting without thinking, interrupting. And so the DSM 5 does have uh, criteria in these three categories, along with the duration and age of onset, in addition to occurring in at least two contexts. So, medical and psychiatric assessment can be utilized, although if the child is being assessed in the medical setting, such as a pediatrician office visit, often it's important to send rating scales home with the parent to be assessed in that school setting as well. It's important for a child with a new diagnosis of ADHD to have a full psychiatric assessment to identify any comorbidities. And remember the decision-making tree for application of the DSM-5 criteria, one of which is no disorder at all. So children coming in for an evaluation for ADHD, brought in by their parents or recommendation of teacher, may not have ADHD at all, may have symptoms of other disorders or no disorder. And so, things to consider for the differential diagnosis is situational hyperactivity. So, is there something going on in the environment? Is there possibly an adjustment disorder? And as well, those other behavioral disorders, tic disorders, and again, substance use, as well as evaluation for autism spectrum disorder or any intellectual disability. So, all of these need to be considered when a child is brought in with a chief complaint of a disruptive behavior disorder. Some of the situations that can be associated with the development of symptoms of poor concentration or hyperactivity in children can include parental mental health issues, severe marital discord or recent divorce, exposure to domestic violence, child abuse or neglect, and as well bullying or exclusion by peers in the classroom setting. Severe deprivation or poverty are also considerations that need to be addressed. And there are a number of behavioral rating scales to use in assessing children who present with a disruptive behavior disorder, such as a child behavior checklist. And we have some ADHD specific rating scales, such as the Connors rating scales, one for parents, one for teachers, and as well an adolescent self report scale. The Vanderbilt ADHD rating scales are available in the public domain, and they include a parent rating scale as well as a teacher rating scale. And rating scales should be used for assessment as well as response to treatment. Treatment of ADHD includes both psychopharmacology as well as behavioral therapies. And some of the best evidence-based treatments include psychostimulant medication. There is a lot of evidence supporting the efficacy of these medications. Of course, they do have side effects that require monitoring, such as decreased appetite or problems with sleep, as well as the cardiac issues. Decreased appetite can cause poor growth if the intake is decreased as well. Behavior therapy includes a number of different approaches, and positive reinforcement or contingency plans can be very helpful. Psychoeducation is important for both parents and the child. There are a number of storybooks, so bibliotherapy is a common approach. Because children with this problem often feel different than their peers. And having a sound understanding of what ADHD is and what it means in positive settings can really help to prevent low self-esteem or anxiety or depressive issues. Behavioral parent training is just that instruction of behavior therapy techniques for parents so that they can do some behavior modification in the home. School-based interventions are critical as well and often include accommodations such as extended testing time, as well as allowing the child to get up out of their seat frequently, and other types of accommodations that are specific to that child. Again, psychostimulants are very efficacious, well studied, and it's best to start at the lowest possible dose and titrate up. Use behavioral rating scales to monitor response to treatment. And there are both short and long acting agents available. The short acting agents often are more psychoactive and may not last into the evening, so the child may have some behavior problems at home or trouble with homework. So it's important to consider whether a long-acting agent is needed. However, long-acting agents can interfere with intake throughout the supper time as well as cause trouble with bedtime. So careful consideration and an individualized treatment approach is necessary. Psychostimulants are not on the World Health Organization list of essential medications, and so treatment is not available to children in many countries. There are some common side effects that do include nausea, weight loss, insomnia, or agitation, and then more serious includes tics, psychotic symptoms, increased blood pressure, or growth retardation. children who have a family member with heart issues or deaths related to heart problems may benefit from having an EKG prior to initiation of psychostimulants, and many areas consider an EKG prior to initiation of psychostimulants as best practice. And here is a helpful graph showing the different agents, both methylphenidate as well as amphetamines, and the different formulations with the dosing schedule and duration of action. There are some non-stimulant medications as well, such as atomoxetine or Strattera, which is an SNRI. It is available in generic, and so available now economically for children and adolescents, and it's indicated for age 6 and above. Quellbri is the new SNRI on the market. It does require prior authorization, and the difference with Quellbri is that there's no need for titration. Once a day dosing right out of the gate is there at 100 milligrams, although an increase can be provided if needed down the line. Guanfacine and clonidine are some additional medications and are usually dosed in the evening with the long-acting agent, and blood pressure monitoring is important with these medications. They are both indicated for age 6 and above, and the pediatric dosing calculations are provided here. And our next lesson will review in detail some of the behavioral approaches that can be used for treatment of children with attention deficit hyperactivity disorder.